All right, everyone, it's 1 o'clock, so I'm going to go ahead and get started. Welcome. I'm Tracy Johnson, the State Medicaid Director at the Department of Healthcare Policy and Financing, or as we like to call it, HCPF. Thank you for joining us today. I'd really like to kick us off first by sharing our updated mission statement. Our mission is to improve healthcare equity, access, and outcomes for the people we serve, while saving Coloradans money on healthcare and driving value for Colorado. This explicit focus on health equity is new, and it responds to health disparities that have been longstanding. They have historic roots in structural racism and systemic inequities. And I won't be the first to observe that the pandemic has further amplified these healthcare disparities. So what this means in a practical sense is that we are applying a health equity lens broadly to our work here. And in order to make healthcare more equitable, we really need to know where our disparities are. So we've done things like added race, ethnicity, disability, geography to all of our dashboards, and now routinely stratify our analyses to screen for and describe disparities to better target our work. This year, we're really focused on two top priorities for reducing healthcare disparities, and they are our COVID vaccination rates and maternity health care and outcomes. And of course, we're here today to talk about the latter. Since its inception in the 1960s, Medicaid is focused on maternal and child health populations, and Health First Colorado, Colorado's Medicaid program, is now the primary insurer for more than 40% of Colorado births. As you'll hear more today, preterm births have remained persistently high in Colorado for decades, and racial and ethnic disparities in maternal health outcomes are similarly longstanding and unacceptable. We'll need to work together on a broad array of initiatives to close these equity gaps and improve health outcomes. Research has demonstrated that Medicaid coverage expansions are an especially effective tool to reducing racial and ethnic disparities. Coverage expansions work because Medicaid offers a rich array of clinical and wraparound services. And over the past 2 decades, HCPF's invested in enhanced services for pregnant and birthing people and sought to drive outcomes through leveraging our status as the larger payer in this space. And you'll be hearing more about this from our team. Applying a health equity lens means explicit focus on populations and population-specific outcomes. And this has required us to reflect on how we organize our work, including how we ourselves are organized. Therefore, we've created a new division of population health that will focus on maternal and child health as well as behavioral health. This division is being led by 2 very strong leaders, Kristen Bates and Susanna Snyder, both of whom you'll hear from later today and are well known to many of you. Additionally, solutions addressing disparities must be guided by our members with lived experience. Therefore, we've established a 16-member maternity advisory committee that's leveraging lived experiences of pregnancies that were covered by Medicaid. And this helps inform and shape policy that will impact pregnant and parenting people across Colorado. Many of these committee members of our new maternity advisory committee have joined us today, and thank you for your contributions. There's a saying in the community of people living with disabilities: nothing about us without us. And this approach has served us well and served our members well. And we'd like to extend it to other core populations. Health First Colorado members are top of mind and at the heart of everything we do here at HCPF. And really looking forward to working with you on all of this. Finally, I'd like to take a moment to thank everyone for joining us today. Being here shows how much you care about the Coloradans and programs we serve. I'd especially like to thank the many advocates like Children's Campaign, All Kids Covered Coalition Colorado, Elephant Circle, providers, CCHN, and clinics that serve the underserved in both urban and rural areas, and many, many other stakeholders, Center for Health Progress, and our legislative leaders that came together to support landmark maternity care legislation this past session. The passage of this important maternal health legislation would not have happened without you. In today's panel discussion, we'll talk about how to leverage this opportunity and other concrete steps we can take to address health disparities and improve health outcomes in maternity care. I'd also like to give a special word of thanks to our colleagues at the Colorado Department of Public Health and Environment for their essential contributions to the Health First Colorado Maternity Report. And finally, I'd like to thank our regional accountable entity partners who have shared with us in this important community level work that's happening on the ground. With that, let's get started. Next slide, please. Here are a few reminders about how the day is organized. The report is posted on the department's publication webpage, and we will put a link to this and other resources in the chat box. So if you want to look at the report while we're going over it, you have that opportunity. Otherwise, though, we want to let you know that the chat is closed. There's 400 of you today, so we've determined that polls may be the best way to get your input in such a large meeting. Several polls will pop up on screen during the webinar, and each will be announced so that they won't surprise you. And please do participate, because we do want to get your feedback and share what you learned today and this meeting with your social networks using the hashtag #COMaternalHealth. And of course, we'd like to continue the conversation. Today's just a beginning, so please keep an eye out for post-event communication that will include resources and an opportunity for you to get feedback. Today's presenters, I'd really like to welcome our team here. We'll begin with Tamara Keeney. She's our HCPF Research and Analysis Manager, who will be presenting the report findings. Susanna Snyder is our Maternal and Child Health Manager, and again, one of our leaders in this new Population Health Division. And what she'll be doing is presenting the maternal health initiatives that we'll be leveraging to help close health equity gaps. And then finally, we'll have two members of our Finance Division, Nancy Dolson, our Special Financing Division Director, and Trevor Abeda, who is our Payment Reform Section Manager, and they will present sequentially innovative reimbursement strategies for programs and providers. Next slide, please. We've also brought together a dynamic panel of guests you'll hear from later on. Kristen Bates, again, our new Population Health Division Director, will moderate the panel. And our panel will include Colorado State Representative Leslie Herod, Deidre Johnson, Chief Executive Officer and Executive Director of the Center for African American Health, Dr. Lisa Latz, Chief Medical Officer of Rocky Mountain Health Plans, which is one of our RAIs, and Dr. Shanti Meyer, who is the Senior Director of Medical Affairs at Stride Community Health Center. And finally, Christina Yabua, Research and Policy Analyst at the Center for Law and Policy. We look forward to their discussion later on. Next slide, please. So HCPF released our first the Health First Colorado maternity report early this week. Again, the link is in your chat. This groundbreaking report creates the foundation to address maternal health disparities, to save lives, and to improve health outcomes. I'd like to introduce Tamara Keeney, our Research and Analysis Manager. She authored this report and led a team that conducted the research and analysis of the findings. Tamara, welcome.
Thanks, Tracy. Good afternoon, everyone. So we began this project because we wanted to create a tool that would provide us with the data needed to understand trends in maternal health and identify targeted interventions to improve maternal health outcomes and reduce health disparities. We can go to the next slide. We were able to create this tool, which takes the form of a Tableau dashboard, through a partnership with the Colorado Department of Public Health and Environment that allows us to link a birthing parent's Medicaid ID with the infant's birth certificate. So it's a unique data source that gives us actionable information. And the report that we released yesterday is an analysis of the data in that tool. So through that linking process, we were able to link 83% of births in 2019. And this report details findings from that analysis and highlights areas of opportunity and improvement. And we encourage our partners to use the report to inform strategies and target intervention. So I'm going to take 10 minutes now to run you through some of the report highlights. Next slide. First, to give you an idea of the scope of Health First Colorado's impact on this population in our state, as Tracy mentioned in her opening remarks, Health First Colorado covers over 40% of all Colorado births. And as you can see from this map, there's a large range by county. So the darker blue indicates a higher proportion of births covered by Medicaid in that county. You can see that there's a range of a low of 14% of covered births by Medicaid in Douglas County to a high of 78% in Bent County, which is on the Eastern Plains. 16 counties in the state, which is a quarter of all of our state's counties, had a Medicaid birth coverage rate of 60% or higher. You can see that those are mostly in Southern Colorado. The report has a table with each county and the percentage of births covered by Medicaid for use by legislators and other stakeholders. Next slide. To support pregnant members, Medicaid offers a set of comprehensive services from the prenatal period through the postpartum period. So this slide just lists out what those services are. You see that we cover prenatal care visits and testing, imaging, labor and delivery, depression screenings, screening, brief intervention, and referral to treatment, also known as SBIRT for substance use, as well as postpartum visits. Next slide. As I mentioned, the report uses a unique data set made possible again through that data sharing agreement between HCPF and CDPHE. And so this slide shows you how that linking process works. So first, HCPF sends CDPHE the Medicaid IDs of members who gave birth. And then CDPHE matches those Medicaid IDs to the birth certificates of those members' newborns. Then CDPHE sends back the matches to HCPF. And in 2019, they were able to match about 83% of births, which is about 22,000 matches. So we continue to work on that 17% gap. Part of the reason for the gap is timing on when we receive claims for the pregnant person and when we send the file. And then the other piece of the gap are our members who are undocumented, who we didn't have in our system prior to them giving birth. Next slide. So one more thing about the report before I dive into the data. When possible, the report uses gender inclusive language, and that allows us to speak to all families and increase visibility for the LGBTQIA+ community. So for example, you'll see us refer to pregnant member, pregnant person, etc. And we acknowledge this is an iterative process, and we encourage your feedback on how we've handled this language in the report. Next slide. Now we can dive into the data. So because racial and ethnic disparities are such a large theme in this report, I want to start by showing you data on the overall race ethnicity of our pregnant members. So this is data from the Medicaid application, which means it's self-identified. So looking at the pie chart, you can see that our Hispanic members of any race represent the largest cohort of pregnant members. So about 39% of all pregnant members in 2019 were in the Hispanic category. That was followed by non-Hispanic white at about 31%. And then following that, we have non-Hispanic multiracial at about 16%. And you can see some of our other groups, non-Hispanic Black at 6.6%, non-Hispanic Asian at 2%. Next slide. So this chart shows a number of the measures we highlight in the report that indicate some of the disparities we see in maternal outcomes. 4 of them are shared here, and I'm going to step you through these 4 measures. So first, the different colored bars represent members of different racial and ethnic categories. So you can see in the legend which colors correspond to which groups. And as we walk through these indicators, I want to draw your attention to a few specific groups. So our non-Hispanic Black members are represented by the gray bars, and American Indian, Alaska Native members are represented in the lighter blue. So the first set of measures that you see here, we show the percentage of members who did not have prenatal care in the first trimester. Research shows that timely prenatal care has the potential to make a real difference in outcomes for both the parent and the newborn. So we see that about 23% of all Health First Colorado birthing parents did not receive timely prenatal care, though Black and American Indian Alaska Native members were more likely to lack this type of care. The second set of bars that you see here is showing chronic hypertension diagnoses. So approximately 7% of all pregnant Health First members report having a pre-existing hypertension diagnosis, but we see that the rate among our Black members is about twice as high as the other groups. The third set of data depicts the percentage of members who delivered via C-section. So this data does not indicate whether or not a C-section was medically necessary, but again, we do see that pattern of higher rates for members who are Black, American Indian, Alaska Native, or those for who race ethnicity is not known. And then finally, we have our last set of data where we see low birth weight, which is defined as newborns with a weight of less than 2,500 grams, which is about 5.5 pounds. So there's a clear pattern here. When you look across many maternal and child health metrics, the ones that we see on the screen and beyond, we see the same disparity again and again. And we know that it's suggesting that there's something deeper and more structural going on. And increasingly at the department, we're calling out the role that member level discrimination and structural racism plays in this persistent pattern of adverse outcomes, even though we can't directly measure it with the claims data we have here. Next slide. The report also touches on behavioral health. So our data finds that 35.5% of Medicaid members who gave birth in 2019 had a postpartum depression screen. I will note this is likely an undercount due to the way we bill for depression screenings. The ultimate goal for screening is that it be universal. So according to the American College of Obstetricians and Gynecologists, there's evidence that screening alone can have clinical benefits. And of course, the maximum benefit would come from referral to an initiation of treatment. The report also briefly touches on substance use. Though our data set is limited in its ability to provide information on substance use among members and potential outcomes for their newborns, we are able to provide insight into neonatal abstinence syndrome, also known as NAS, and that refers to a newborn's withdrawal from substances that their birthing parent used during pregnancy. So in calendar year 2019, about 3% of infants received a diagnosis for NAS, and rates were disproportionately higher in El Paso, Pueblo, Jefferson, and Larimer counties. Next slide. The data set also gives us information on health behaviors. So one of the health behaviors that we cover in the report is smoking tobacco during pregnancy. About 1 in 10 members said they smoked tobacco during pregnancy, but you can see that there's wide variation among our different racial and ethnic groups. Non-Hispanic white members were the group who said they were the group that was most likely to say they smoked during pregnancy. And you can see that their rate of smoking of 18.8% is about 3 times as high as Hispanic members at 6%. Next slide. We focused on smoking during pregnancy because we know it can have harmful impacts on the newborn, and it's really an opportunity for intervention. So the advantage of this data set is to be able to do exactly this kind of analysis to compare risk behaviors during pregnancy with birth outcomes and have a Colorado Medicaid specific data point. So here we see that members who smoked during pregnancy were much more likely to give birth to low birth weight babies than those who didn't smoke. So among members who said they smoked during pregnancy, 16.2% gave birth to a low birth weight baby compared to 9.7% among those who were not smokers. And we've shown this data to our regional partners, and those conversations have spurred a new emphasis in smoking cessation in regions with higher rates of smoking. One last graph for you. It's another example on the next slide of another analysis that we did looking at the health of the birthing parent and then the outcome for the newborn. So here we're looking at preterm birth among those who had a chronic hypertension diagnosis and those who did not. So we can see over 20% of members with chronic hypertension delivered preterm newborns compared to 9.6% without a pre-existing hypertension diagnosis. So this data point really points to the need for comprehensive prenatal care, and particularly a focus on our Black members, who you might recall from an earlier slide had a hypertension rate twice as high as other groups. And again, this really points to the opportunity for comprehensive prenatal care, which might include things like education on nutrition and exercise, as well as potentially medication to help control hypertension. So on this last slide, we couldn't get to all of the topics that are in the report in 10 minutes. So I invite you to dive into the report and explore all of the other topics that we have covered there. So with that, I will turn it back to Tracy.
All right, so next up, I would like to introduce Susanna Snyder. She is our HCPF Maternal and Child Health Manager in that new division of Population Health, and she will now present some maternal health initiatives that we can leverage to close health equity gaps. Susanna, take it away, please.
Thank you, Tracy, and good afternoon, everyone. Given the added stressors our members face, compounded by the stressors of pregnancy, the department has a long history of special programming for pregnant and newly parenting folks. Tracy mentioned some of these initiatives earlier, but we wanted to provide more information on what we currently offer. And in light of our new health equity data, share some ways we're rethinking these legacy programs and invite future feedback on how we can continue to reimagine their impact. Next slide, please. First, I'll discuss Prenatal Plus. This is for birthing people at risk of adverse birth outcomes. It's offered prenatally through 60 days postpartum and uses a risk criteria to enroll women in the intervention, which is team-based care that includes a mental health professional, a dietitian, and a specialized perinatal care coordinator. That is in addition to your obstetric care. The program's offered through 4 tiered packages, ranging from a low level, that's 1 to 4 visits later to care, or all the way up to a package of over 10 visits with early entry into prenatal care. At the highest intensity package, we have birth certificate data showing that while those enrolled in Prenatal Plus are usually considered higher risk, they still have improved outcomes over pregnant Medicaid members not enrolled in Prenatal Plus. This means we have a higher than Medicaid average of Latinx and adolescents enrolled, yet we still see reduced low birth weight and preterm birth among enrollees. Realizing the impact this can have on our BIPOC members, we are expanding our eligibility criteria. Currently, criteria for program entry includes physical risk factors like gestational diabetes, then more social determinants of health risk factors like housing instability, and finally, life stressors, including something such as a recently incarcerated partner. To be more inclusive to shifting state demographics, we recently added English second language and refugee status to that list. And now, given our enhanced understanding of how lifelong experiences of racism impact health and well-being, as well as episodic incidences of racism within the healthcare system, we're in the process of adding a risk factor that would confer eligibility into the program based on an experience or experiences of racism. Next slide, please. Our next program is Nurse Family Partnership. It provides home visiting services to first-time birthing parents prenatally through the child's second birthday. It's delivered in partnership and really led by the Colorado Department of Human Services and state champion of evidence-based programming for families, Invest in Kids. The program has an enormous body of literature showcasing its efficacy. This includes, but is by no means limited to, reduction in preterm birth and postpartum depression, and even longer lasting impacts can be seen in increased educational attainment for children whose birthing parents received NFP services. Currently, Medicaid only covers approximately 5% of the funding, but we're continually trying to improve that percentage to maximize federal funding so we can further sustain precious state funding. While home visiting was a little problematic during COVID and has slowed some of that work with CDHS and Invest in Kids, it's a constant conversation. And we think it's extremely important with what we know about patient-provider concordance and its impact on infant health. When the birthing parent and the provider identify as the same race or ethnicity, infant mortality declines. Because of that, Invest in Kids is working on innovative strategies to recruit more nurses from the communities they will be serving. Next slide, please. Our third program is our oldest Medicaid-supported program for pregnant and parenting people. Special Connections is gender-responsive, trauma-informed continuum of substance use disorder services for pregnant and parenting individuals up to 1 year postpartum. This provides a range of services from outpatient to more intensive residential treatment, and it's existed in partnership with the Office of Behavioral Health since 1992. It was our only adult residential inpatient SUD benefit until January of this year when we rolled it into our statewide benefit for all Medicaid enrollees. While it's been absorbed, we've retained special criteria, including unique provider types, that OBH licensure to treat this population, an expedited timeline for this population to approve stays at 24 instead of 72 hours, and an initial authorization for 30 days for all these members based on the inherent complexity of being pregnant or postpartum in recovery. Another evolution of the program, to get federal authority for the statewide benefit, we were required to use a nationally recognized assessment criteria. It requires us to consider what they call recovery or living environment of an individual and its impact on their successful recovery. So we can now explicitly include a host of social determinants of health into determining the most effective course of treatment for all of our members. Next slide, please. More so than a single program, our regional accountable entities are our most important partners in impacting the outcomes for members. As 7 regional entities that are responsible for improving member health and reducing costs, they have performance and program standards around maternal health programs, an area deemed so important that it's included as part of our governor's wildly important goals. First, the pay for performance efforts include a prenatal engagement indicator that's measured quarterly and results in increased payments to the entities and ultimately to the providers in their region, rewarding increased prenatal care rates. Second, a premature birth rate measure and our annual, more flexibly determined and dispersed metric pool. While those are more outcome-based, we also have new contractually required condition management standards. One of the greatest strengths of this model is its regional responsiveness. Given the diverse geographies of our state, rural, urban, frontier, tribal, refugee, and more, our delivery system needs to be responsive to the needs of the regions. For example, our smoking rates in pregnancy tend to be higher in rural and frontier areas, but our Black population with their unique needs tends to be concentrated in our urban areas. So the RAISE can respond to those differences accordingly. While Region 1, where one of our panelists, Dr. Lisa Latz, works, has invested in a strong NFP referral program, another region may find a stronger need to partner with another evidence-based tobacco cessation program like Baby and Me Tobacco Free. Yet that strength and variety can also lead to challenges of monitoring rate performance across regions. So recognizing this, the department has set forth new criteria to standardize access to quality maternal health programming. This resulted in stronger condition management requirements added to recent contract amendments. It's an iterative process, navigating regional flexibility with universal standards of accountability. Our third major area of work with ARRAYS is leveraging of this very data discussed today. Tamara presented on our statewide data, but our dashboard allows regional comparisons. With our new dashboards, we've started program and data meetings with ARRAYS to share our data and dialogue about existing and potential programming to tackle issues identified. Next slide. Finally, our newest initiative that's come up a couple times. Tamara discussed how it's a struggle to measure the experience of race and the impact of racism. This includes both that aggregate experience of the chronic stress of racism and its impact on health, as well as specific experiences in which implicit or institutional racism may impact the health outcome of an individual. While the data in the report is illustrative, we need to go further to deepen our understanding. This means giving these numbers a narrative, to ask people with lived experience to share their stories. When the department began the maternity bundle that Trevor Abeyta will discuss shortly, some community partners, many of whom are here today, encouraged the department to create a maternity advisory committee composed primarily of Black, Indigenous, and people of color with lived experience in Medicaid maternity care. Since then, our team has been working hard to make that vision a reality, including ensuring we're complying with industry best standards to provide stipends for time and childcare, as well as translation services. Through stakeholder engagement on the application, which was translated into 5 languages, and an extensive outreach process, we received over 100 applications from eligible Medicaid members and interviewed 35 candidates. It was tough, but we selected 16 exceptional committee members, of which 80% identify as BIPOC. We hope this group can do things like review program data shared today, tell us about the things we can't see in our pretty graphs, provide input on meaningful metrics to inform our innovative payment models you'll hear more about from Nancy Dolson and Trevor. Ultimately, we want them to make recommendations to the existing programs I just discussed, as well as many exciting upcoming ones. Stay tuned for those follow-up materials and how you too can be involved in those new programs. With that, I will turn it back to Tracy. Thank you.
HCPF created new innovative reimbursement strategies, leveraging our role as the largest payer of maternal health in Colorado. These reimbursement strategies support providers and programs in the maternal health space. So now I'd like to introduce HCPF Special Financing Division Director, Nancy Jolson, who will be immediately followed by Trevor Abeda to talk about two such initiatives. Thank you, Nancy. Take it away.
Great. Thank you, Tracy, and good afternoon, everyone. It's my pleasure to be here with you all today. Next slide, please. So we know that hospitals are an important part of our healthcare delivery system, and they have a key role in improving maternal health. Today, I'll briefly describe our current hospital incentive payment programs that have perinatal and maternal health measures, our hospital quality incentive payments, and our hospital transformation program. These measures are aligned with and complement our regional accountable entity performance measures that you heard about just a moment ago. And these incentives are paid outside and in supplement to or in addition to hospitals' Medicaid claims-based payments. Next slide, please. Great. First, so to talk about our hospital quality incentive payments, or we sometimes refer to this as HQIP. This is about $90 million a year in dedicated Medicaid funding for our hospitals, and its goal is to improve the quality of hospital care for Medicaid members using nationally recognized performance measures. Next slide, please. HQIP has three main focus areas or measure groups for hospital improvement. First, the perinatal maternal care measure group, which I'll discuss a little more in a moment, our patient safety measure group, and finally a patient experience measure group. Next slide. Great, thank you. And here you can see the components of the HQIP maternal health and perinatal measure group. And to touch on a few of those, our C-section measure counts the number of first-time births of a full term, single, so not twin or multiple, baby in a vertex or not breech position that's delivered by cesarean section. Our maternal emergencies measure is based on the National Partnership for Maternal Safety Consensus Bundle on severe hypertension during pregnancy and the postpartum period. And a reduction of racial and ethnic disparities measure gathers information on a few key questions, including, does the hospital system accurately document self-identified race, ethnicity, and primary language? Does it provide staff-wide education on peripartum racial and ethnic disparities and the root causes? Does the hospital engage diverse patient, family, and community advocates who can represent those important community partnerships on quality and safety leadership teams? Does it provide staff-wide education on implicit bias? Does the hospital ensure that providers and staff engage in practices for shared decision-making? And does the hospital have initiatives in place to build a culture of equity, including systems for reporting, response, and learning, amongst others? Next slide. Similar to HQIP, the Hospital Transformation Program is designed to improve health outcomes through pay for performance incentives. Hospital Transformation Program, or HTP, also involves hospital supplemental payments that are paid in addition to the hospital's Medicaid claims payments, and it is funded by hospital provider fees. The HTP is launching this year. Hospitals are currently in the implementation planning process. And HTP is going to bring value-based purchasing strategies to more than $1 billion in annual hospital payments. So a lot of incentive capital here. Next slide, please. Under the Hospital Transformation Program, there are 5 priority areas where hospitals will be incentivized to improve healthcare delivery and outcomes. First is reducing avoidable hospital utilization. Second, focusing on Medicaid core population, and this includes maternal care. Improving behavioral health and SUD care, or substance use disorder care, improving clinical and operational efficiency, and addressing population health and total cost of care. Next slide. Under HTP, the specific maternal measures are under that core population focus area, as I mentioned, and those are social needs screening, and that includes screening for housing instability, food insecurity, transportation problems, utility help needs, and interpersonal safety. A patient with a positive social needs screen must be referred to an appropriate entity, and the regional accountable entity must be notified. With reducing neonatal complications, this will measure the percent of infants with unexpected severe and moderate complications, which will include severe birth injuries, severe or moderate respiratory infections or complications, and infants with prolonged lengths of stay. And the screening and referral for perinatal and postpartum depression and anxiety will measure the percentage of patients screened at any hospital encounter during pregnancy or 60 days postpartum, where again, the regional accountability entity must be notified, and that RAY notification needs to happen within 1 business day of a positive screen. So this concludes my overview of our maternal health components of our hospital incentive payments. And next, I'd like to introduce and turn it over to Trevor Abeyta, HCPF's Payment Reform Section Manager, to discuss more of our innovative maternal care payment strategies. Trevor.
Thank you, Nancy. And thank you so much, everyone, for having me here today. And I'm excited to share with you the department's maternity bundled payment. The maternity bundled payment ties obstetrical provider payment to patient outcomes. And maternity bundled payments have been shown to work in other state Medicaid programs as well as commercial insurers. Next slide, please. We started our maternity bundled payment as a pilot program on November 1st of 2020 with 3 obstetrical provider groups. And I'm excited to announce that we're planning to expand the maternity bundle to cover all Medicaid deliveries by July of 2023. We're so excited to expand the quality improvement potential of this program to all pregnant people enrolled in Medicaid. We started our maternity bundle with the focus of reducing cost by improving quality. And this is what every maternity bundle in the country does. But we partnered with stakeholders to start our maternity bundle, and they helped us to focus on addressing health equity and preventable maternal mortality. 2 of the things that we've done to focus on health equity is we've partnered with the department's Maternity Advisory Committee to provide strategic direction for the program. And we're requiring all obstetrical providers who participate in the maternity bundle to take a cultural competency training. According to CDPHE, the leading causes of preventable maternal mortality are suicide within a year of giving birth, followed closely by accidental overdose. And we've designed our maternity bundle to pay obstetrical providers an incentive payment for enhanced screening, referral, and follow through to both substance use disorder and mental health treatment. To accomplish our goals, the maternity bundle creates a comprehensive budget, which is inclusive of all prenatal, delivery, and postpartum care. Obstetrical providers can earn incentive payments for keeping costs below the comprehensive budget. But to ensure that high quality services are still being provided, providers must meet a quality metric gateway, which I'll discuss more on the next slide, to earn incentive payments. Next slide, please. The first year of the maternity bundle was reporting only on quality metrics, and we did this to set a baseline for quality for the participating providers, as well as to see what metrics were reportable with the department's data. We are working with our department's Maternity Advisory Committee to select a final 3 to 4 measures, which will be tied to payment in the second performance year of the program, which begins on November 1st of this year. We're focusing on both clinical outcomes and process improvement measures. And importantly, highlighted at the top is postpartum depression screenings. And this is important because of the mental health aspect of preventable maternal mortality. Nancy and I want to thank you for having us here today to talk about the department's innovative reimbursement methodologies for maternity services. And we want to thank each and every one of our stakeholders who's helped us to design some of the most innovative payment methodologies in use for maternity services in any Medicaid program in the country. And with that, I'll hand it back to Tracy.
Thanks, Trevor and Nancy, and many thanks to all of our HCPF colleagues for their dedication to this work. Many hearts and minds contributed to the creation of the maternity report, to the development and passage of the maternal health and family planning legislation this session, and really over the last couple of decades, and to implement the innovative programs that you just heard about that are really helping our providers drive meaningful change to our members and in the health equity space. We appreciate you, and we're grateful to our stakeholders for their passionate contributions. The next portion of this event today is really working with our panel, and I'm pleased to introduce Kristen Bates, the department's new Population Health Division Director, and she will moderate today's panel. For those panel members that have not yet turned on their video, I invite you to do so, and please take it away, Kristen.
Hello, everybody, and good afternoon. Thank you so much, everybody, for all of your work so far. I've been in the background in the backstage area with some of our panelists listening and learning about the work so far. So today what we're going to do in the next 45 minutes or so is welcome our esteemed guests and panelists for the webinar and go through a discussion, kind of a Q&A discussion with them. So first up, we have Colorado Representative Leslie Herod. Is Representative Herod on the call yet? Okay, should be coming
Hello,
shortly.
I'm here. Sorry about that.
Oh,
I was
okay.
in the audience. Thanks.
Kelly, can we make sure we can get her video up there? There we go. All right, and then we also have Deidre Johnson, the CEO and Executive Director for Center for African American Health. Hello and welcome, Deidre. We have Dr. Lisa Latz, Chief Medical Officer for Rocky Mountain Health Plans, one of our RAYs. Hello, Lisa. We also have Dr. Shanti Meyer, the Senior Director for Medical Affairs for Stride Community Health Center, a federally qualified health center in the Denver region. Hello, Shanti.
Hi, everyone.
And last, we have Christina Yabua, Research and Policy Analyst from Colorado Center on Law and Policy. Hello and welcome, Christina.
Hello.
All right, wonderful. Okay, so I'm going to go ahead and start off and just ask a couple of these questions. And after hearing the data, we really want our discussion to talk a little bit more about, the intersection between the data, the programs, and maybe what this means for Colorado. So Representative Herod, why don't you tell us a little bit about what you've heard from your constituents on the issue of maternal health equity and why this issue is so important and such a passion project for you?
Absolutely. Well, first, thank you for doing this work. I appreciate your commitment to infant and maternal mortality and also racial equity and justice, which is really highlighted in this report. And I also want to thank my colleagues and friends who are on the panel with me today for your work in the community. I think that my constituents clearly have asked for change. I've heard loud and clear that the rate of infant and maternal mortality is unacceptable throughout this country, in Colorado, and even right here in Denver. But it's particularly problematic for Black women, Indigenous women, and other women of color. And I should say people of color. And that is something that we should all be concerned about. And to add insult to injury, we are paying more than any other nation for the birthing process and have some of the worst outcomes. It doesn't make any sense. And so my constituents have said loud and clear that we need to do something about it and that this needs to be a priority for the state of Colorado. And we've taken that issue on.
Thanks, Representative. I don't know if you had a chance to look at some of the report or listen today. What were some of the findings that really resonated with you?
Yeah, well, I'm going to look at my notes a bit, so excuse me for looking down. But I think what really stood out for me is definitely the racial disparities. I see and look at the numbers, and what I see is that definitely not only disparities at the individual level, but the systemic level. I think what was really clear was that we have systems of inequality that results in poor outcomes in the birthing period. And so what I'm talking about is the clear health issues that we have in our community, including issues around hypertension, the stress of racism, redlining, the connections to police violence and violence in our communities, and how that really does have an impact on healthy birthing outcomes. And so the pattern, I think, of medical care that fails, particularly people of color, is clear. And it's something that we saw, I think, in this report. And I think the failure to listen is something that I've heard from Black women consistently over time, which is that, Black women and Black people are going to seek care and their pain is not being addressed, realized, or even believed. And that's something that I think, as I talk to Black folks in the community, is felt by all, including myself. And it's something that we have to be self-advocates for, but quite frankly, the system needs to address and change. And so, I think the The other thing that really struck me was the C-section rates that were higher for Black people. And I think that that's something that I really think we need to address and dig into even more, because it's extremely worrisome. And then finally, I think the underutilization of midwives is something that we need to address here in Colorado if we want to see a change in outcomes. And I want to note that my mom is an OBGYN. She got into the field because of Black women in particular, and specifically not being believed, and the poor birthing outcomes, but also knowing the gift that it is to bring more beautiful Black children into this world, and making sure that they have a positive journey into our society. And so I have nothing against OBGYNs. In fact, I think it's quite amazing, and really is the root for why I do this work, is my mother. But we know, quite frankly, that since she's been in this work, that the outcomes haven't really improved. And so we need to make sure that people in our communities and communities across Colorado have other options. And that's why I think midwives are so very important. Having someone who is even, just a little bit closer to the family and to the person giving birth, I think is just so important. It's rare that you find, Black women like my mom in the field, and my mom is since retired. But it is less rare that you see midwives who are of color. And so I think it's just really important that we elevate midwives and the practice of midwifery, and that we make sure that we value them as a state and as a healthcare system. So there's a lot of things that stuck out to me in the report, and I'm going to pour myself into it a little bit more so that we can really continue the work and our commitment to make sure that we have better birthing outcomes for all people in Colorado. So thank you for that question.
Thank you so much, Representative. And we are going to talk a little bit about the clinical aspect, but first let's follow up with Deidre. Can you talk a little bit more about the role bias and systemic racism play in maternal health disparities, particularly in populations served by the Center for African American Health?
Yes, thank you again so much for having me here today. And I really want to echo what the representative just shared. African Americans experience excess death across the spectrum. What we know around maternal mortality is typically we die at a rate 4 times more than our counterparts. And if you're in New York, it's can be 12 times. So, and the reason this particular disparity hits home and strikes at the heart of things is when you control for education and social economic status, nothing changes. So you can actually be a white woman with a high school diploma, and you are guaranteed to have a better birth outcome than a Black woman with a PhD. And that this is one of the things where, yes, there are issues with regard to social determinants of health as well as access. But at the end of the day, the root cause is the systemic racism. And I think there are a couple, like being a woman in general is a challenge, especially when you think about the fact that our society, once you're pregnant, kind of sees you as this vessel for the pregnancy versus as a human with your own needs and supports and needs during this journey. And so even, I think it was right before the pandemic, we had there was a story in California where a white mother just said, I'm having some difficulties, and suddenly she's arrested. So just being a woman is the first issue. And then laying on top of that, being an African-American woman, some folks call it weathering, but just navigating kind of what is this experience of living in a racist society takes its toll in ways we're only now discovering. What excited me about what I saw today and some of the recent dashboards that you guys have created is the fact that you're measuring things, and people measure what matters. And for so long that the request was just measure it. And I like the fact that you're diving in and changing things, because you got to start somewhere. There's not going to be a magic wand. I think of it in 2 perspectives. Yes, there is the individual. How can we help them kind of navigate the system? But ultimately, the system has to change. I'll just share very briefly. So my mom's a nurse. And this happened for me 17, 18 years ago. I ended up in ICU twice after being pregnant and giving birth with postpartum preeclampsia. And why I share that is I had great prenatal care. I had a mom who was a nurse. I just knew the system. But the moment I was in need, I was met with, I wasn't listened to. I presented immediately after my first birth with, my blood pressure is high. Actually, even during the last couple of months, oh, you people, you're always high. And that's actually what was said to me. But I had such a vascular headache, I couldn't react to that. And then within 24 hours, I was suddenly there again. But this time they paid attention because I was on the verge of having a stroke, kidney failure, brain swelling. And we shouldn't get to that point. And the tragic thing about it is there are too many stories like that. Many of them don't have a happy ending. And while I am thrilled by the supports that you all are planning to put in place, that are going to be so very important, until we really get to that root cause, we will always have to do this. So I like the idea of let's treat everyone, every Black mother as high risk, just to make sure we've got that nest of supports to do our best by them. Because at least it'll force the conversation of how are we going to rip the roots out of this systemically racist society we're in and just do better by everyone.
Thank you so much, Deidre. Yeah, I mean, it's when somebody who has all of the resources, money, knowledge, even clinical expertise in the family, I mean, can't get the care that they need. It's just so tragic. And I'm so sorry you had to go through that. Christina, my understanding is that CCLP is an anti-poverty organization. So tell me a little bit about the anti-poverty lens here and how an anti-poverty organization and why you're interested in prenatal care and birth outcomes.
Awesome. Yeah. So first and foremost, I do want to give a shout out to the other consumer advocates that have been really involved in this issue. Elephant Circle, Children's Campaign, Color, Clayton Early Learning. They've all been, excellent thought leaders in this space. And I'm honored to stand before you, not just on not only representing CCLP, but also the consumer advocates for Colorado. But back to your question, like what the heck is CCLP doing here, right? The topic areas of poverty, racism, and health are all interconnected. We know that the status quo wasn't designed to work for the most marginalized groups of folks. Quite the opposite, actually. It has these built-in features that disadvantage the most marginalized. And so as you'll hear throughout today's presentations and the panel that we've already discussed, maternal racial disparities are largely attributed to systemic racism. And we also know that the cycle of poverty itself is heavily related to systemic racism. And so as CCLP is anti-poverty, we wouldn't be doing our due diligence if we weren't inherently anti-racist. And although we're seeing outcomes for Black and Brown patients that supersede income level, as Deidre pointed out, we know that poverty further exacerbates a lot of these issues. For instance, lower income Coloradans face a lack of continuity of care. A lot of them see different providers for each visit, and then they don't know who their provider is going to be for labor and delivery. Sometimes they lose access to care right after labor and delivery. They have problems with their transportation. Inconsistent housing can also lead to a barrier. Some of them face derision and suspicion, sometimes even punishment, if they're unable to make standardized appointment schedules without any kind of accommodation for their employment or for their transportation or housing circumstances. And all of those lead to the outcomes that we have already been mentioning in the report. And what's interesting is that this is kind of a cyclical phenomenon, right? So poverty correlates with poor health outcomes, which then can lead to costly medical bills and extra time off of work without pay. And for some folks, housing complications, all which contribute back to the cycle of poverty. So with this in mind, the conclusion is that you can't really address maternal health without talking about poverty and racism. When really looking at the web of the interconnection, the only logical conclusion is that birth equity is economic justice.
Thank you, Christina. All right, let's have our clinical teams talk a little bit right now. So Dr. Latz, you are, in addition to your role as Chief Medical Officer for one of the regional accountable entities in Colorado, you also still see patients. So why don't you tell us a little bit about what type of medicine that you practice and how the report relates to what you see in the exam room?
I will, thank you. And thank you so much for having me here, Kristen. And I first want to start by just commending the department on this report. I don't know if those of you listening understand how difficult it is to mirror maternity data with birth outcome data, it is so hard. And so the fact that you were able to do it and match it in 85% of the births is just extraordinary, and enables us to have this beautiful report that gives us really amazing data that we can act on and you know, do legislation on and programs around. So it's really impactful and so hard. And so I want to commend the department on being able to do that. So clinically, I'm an internist, and I have a subspecialty in high-risk OB, which is a very unusual specialty. So I see patients in clinic who have medical problems, so high blood pressure, diabetes, seizure disorders, heart problems, et cetera. And so our clinic is mainly a Medicaid clinic, Medicaid and undocumented women who don't have insurance at all. And so we see a lot of refugees. We see a very diverse group of women, both from a ethnic perspective, a cultural perspective, racial perspective, and they all have lots of problems. And we have the luxury in our clinic of having more time than usual to see people. So typically we can see people for 40 minutes, 50 minutes, an hour even, since we're sort of a group clinic if the woman needs it. So we're able to take care of individual problems and see women very frequently, sometimes weekly throughout the course of their pregnancy, and get a handle on problems. But our clinic is fairly unique. And what really strikes me is that there's an incredible need here, and the resources around our state are good, but don't always meet the risk of the highest need women. So we tend to treat towards the largest denominator and the most common problems. But when you have women that have very specialized problems or special circumstances, it isn't always easy to get to the bottom of that. So that is one thing. But you know, in our clinic, we're able to do that. The other thing that really resonated with me in particular was the C-section rate and the disparities in that. Typically what we expect to see is that Medicaid has a lower C-section rate than the state as a whole. And it probably is lower than the state as a whole, but it's still really high for Medicaid. And so that's something that as a group, we should be looking at tackling.
Thanks, Lisa. Dr. Meyer, why don't you tell us a little bit about your clinical expertise as well, and how you think different obstetric providers can collaborate to help provide better whole person care?
Absolutely. I'm very happy to be here. And as everyone has already said, I'm so impressed that this work has already been done. And particularly Representative Herod, who I know has been really at the forefront of a lot of the legislation that has come through this year. And I am a nurse midwife by trade. I also have a PhD. And so, of course, any shout outs to midwives are greatly appreciated by myself. So I work at a federally qualified health center, which serves one of the largest geographical areas in the state. And we serve 50,000 plus people a year. We serve several hundred, over 1,000 pregnant patients every year as well. And we have a combination of the majority of our providers are nurse midwives, and then we have a handful of family medicine physicians as well. And what I have found throughout my entire career as a nurse midwife is we have a really amazing system of providers in the United States that I don't think we really are taking strong advantage of as far as their training and their scope of practice, how they interact with women, and really what their specialties are. Nurse midwives are trained to deal with low and moderate risk patients who are pregnant. And we are trained to really be with them throughout their pregnancy and birth and postpartum, get to know them, get to know their families. A lot of, again, what Representative Herod was saying. And I am a huge fan of our obstetricians. I'm a huge fan of our maternal fetal medicine specialists, internists with high risk OB training. And we really, if you look at us as providers as a whole, we have the ability to really take care of pregnant people where they're at in their risk level. But what we don't do in the United States is exactly what Representative Herod was saying. Right now, I was actually pleasantly surprised to see that nurse midwives serve 18% of the Medicaid population In reality, we should be serving about 70 to 75% of the population if you look at just risk status for people who are pregnant and giving birth. Our obstetricians, our maternal fetal medicine specialists, their training is specifically around high risk pregnancies and birth. And that's where their training and expertise should be used. And unfortunately, I think as a culture, we really are, I think there's this idea that, well, if I go to a physician, I'm going to get better care. And in some cases, that's absolutely true. But if you don't meet those risk requirements, a lot of times there are more interventions that happen. There's lots and lots of evidence, and I'm happy to send out any research articles about how midwifery care for a lot of women have improved outcomes, both for moms and pregnant patients and for their babies. And I'm going to do my plug in every single question that you ask me about my goal to make a birth center for our FQHC patients, because right now we really only have one birth center in the state that takes Medicaid and actively takes Medicaid. As you saw from the report, less than 1% of our pregnant Medicaid members used a birth center in 2019. And that number really should be a lot higher. Freestanding accredited birth centers have a lot of evidence behind them. They're state regulated, they can be accredited, and there's a lot of evidence base that outcomes for, again, both pregnant people and their babies are equal, if not better, at birth centers. And we're really underutilizing that in our state. And that's one of the things that I've been a huge advocate for in my career. I opened up a birth center up in Boulder, and it was really great and it's very successful. And then I really needed to get back into Denver metro area to really work with the population that I started with. And I think myself as a queer woman, it's really important that we are recognizing everybody for where they are. And I think being better with efficiency around the providers that we have within our system is really the best thing that we can do for the obstetric care for our patients. And we're all needed, but we're needed in different ways, and we're not using our providers in the way we really should be using for care. Thank you.
Thank you so much, Shanti. That was great. I'm going to actually follow up with Deidre a little bit on what we had talked about before about advocating for yourself and providers that can be dismissive. So how can a patient or a family member learn more about how to advocate for themselves or their loved ones when they are being dismissed or concerned about being dismissed by providers?
It has a couple of levels for me. I think one of the things that folks had mentioned before was, the role of midwives and doulas as well is having that person who kind of walks with you along that journey. Because to be honest, when something goes wrong, I wasn't coherent once things were happening. So it was a family member and others who sounded the alarm. And, there are things we can tell folks to do, regardless of care, going in with different questions. But the trick is making sure those questions are answered. And I'll share a couple things that are system related, but not specific, but these things happen. I had someone I know who had ovarian cancer. She had gone to the doctor about 5 times. It wasn't until the 5th time, after being dismissed, oh, you're stressed, oh, you're not taking care of yourself, when she really demanded, these things are happening to me, that they realized, oh my goodness, you're stage 4. Had she been listened to, the trajectory would have been much different. I had a cousin who passed away from cancer a couple years ago. And it wasn't until I heard from his kids, hey, Cousin D, we have a palliative meeting, but we haven't even talked to an oncologist. Can you come help? And so these things are happening where families aren't given just the basic information you would think so they can make these decisions. And so my logical heart and mind is, it's great to help people understand, here's what you can do, but we need to flip it. Why should people have to morph themselves to respond to the system? The system needs to respond to the people. And part of that is really anti-bias training. I'm a huge fan of midwives. Unless the numbers have changed, pre-pandemic, we had 1 Black certified midwife in the state of Colorado, and she's in Springs, doing amazing work and probably overwhelmed. And so how can we reduce the barriers to get more of those? I know we've got efforts to have more doulas. We've been working in partnership with Families Forward to have more certified lactation specialists, and we're about to do a navigation project with them along with the Colorado Hospital Association. But at the end of the day, we need to have not only health system providers, but also community providers with that anti-bias training. Because what was eye-opening for me coming here from philanthropy was being on the community side. And I know very well-intentioned community providers talking about the work we do today that are going into homes, and because a Black family may opt out, they're not looking at themselves thinking, how can we do this better? They're assuming, they're demonizing that family. Oh, you don't need to come to your house, rather than thinking this should be a relationship. If you don't know me, you're not getting into my house. Don't assume that I'm suddenly ensnarled in the child welfare system. Just get to know me. And if we could slow down, require anti-bias training, and treat people the way we would treat our own family members, so much of this would help us move forward and cost a lot less.
Thank you, Deidre. Well, I'm going to go back to Shanti for a minute to talk about culturally sensitive integrated care. So this is something that you're a big proponent of and you're passionate about this approach. So can you talk a little bit about the success that Stride has seen and how integrated care helps you address health disparities?
Absolutely. And Deidre, I do want to let you know that there's more than one Black midwife in Colorado. And it's really important for us as an agency also, I think somebody else had mentioned this, to really have providers who are either from the communities or look like or speak the same language as the patients that we're serving. So that's been definitely something that I've been working on since I've been at Stride. But what I'm really proud of about Stride and many other FQHCs is that we have a really strong integrated care model, and specifically for our pregnant patients. So in every clinic that serves pregnant patients, we, not only have the provider, either, primarily a nurse midwife or a family medicine physician, and we also have our medical assistant. We've got a prenatal specific care manager, and their responsibility is really addressing those social determinants of health. So they do a really good, thorough assessment with every pregnant patient. They meet them at the very first visit and go through any insecurities they have around food or transportation or housing, and get them connected to resources, which is really amazing. They connect them with Nurse Family Partnership or WIC from the very beginning. And then we also have behavioral health within our clinics as well. And we always do warm handoffs if something comes up, but also they meet again with every one of our new OB pregnant visits so that they can introduce services and kind of do that mental health assessment, because, as we know, many women and pregnant people really do suffer from anxiety or depression or other mental health disorders. And so being able to address that from the very beginning is really important for the longevity of the pregnancy and for both maternal and newborn care. And then we have some nurses that help. We have certified diabetic educators. We're starting a program where anyone who is diagnosed with gestational diabetes will be connected with our diabetic educators to start on insulin and get that more comprehensive, acute education and needs around being diabetic. We've got a pharmacy. We've got Title X funding right now so that we can offer our undocumented and uninsured women contraception or family planning services either before or after their pregnancy. We have many providers who either speak Spanish or other languages outside of English, which is also really important. We screen about 70% of the incoming refugees to our state, and so a lot of those people need to speak other languages, and so that's really important to get them connected as well. We also recently joined the Centering group, which provides evidence-based group prenatal care, which again is really evidence-based for lowering preterm birth and low birth weight. We're in the process of getting on board with Prenatal Plus. We've got a MAT program to help with people who are wanting to get off opioid addiction. And what else? We've got some lactation consultants at our clinics. So it really feels like what we try to do is is really assume that all of our patients need all of those services, and to be able to address those from the very beginning and throughout all of our visits with our patients, so that if problems arise or issues arise, they're able to be addressed and they know what our services are from the very beginning, which is really, really important. And if they don't need those services, great. We're at least telling them that that's something that we care about, and that if they develop later in the future, then that's something that we can approach with them. But I really think that the whole issue around poverty and systemic racism is absolutely multifactorial. And so being able to provide all of these services to our patients, and to be able to meet the needs for whatever anybody specifically might need is super, super important. And we try every day to meet the needs of our patients, and know there's probably a lot more we can do. So this data is really, really helpful for us to continue to do the work that we want to do. And again, I'll do my little plug for a birth center, because that's the one thing that we're missing right now. We have really strong continuity of care with our providers. Patients who come in get assigned a provider, and then that provider gets to stay with them throughout their pregnancy and into their postpartum period, which is amazing. But then what happens is we don't have the ability right now to be able to be with them for their births. They go to a hospital. That's a really vulnerable time of their pregnancy and birth, and to go into a system that they don't really know. I was very interested to see that probably about 17% of the people that you were not able to match their newborn records with might be undocumented. We have a high rate of undocumented patients that see us. And it's probably 45% of our pregnant patients. And a lot of them aren't coming to care because they don't think that they can get it covered. And I can tell you that right now, I am very aware that the state does not pay for prenatal care for our undocumented women. And that would be something that I would really strongly advocate for any future legislation, because that they're people too. They deserve amazing prenatal care and health care throughout their lives. And I cannot tell you how many times I have patients come in 24 weeks, 36 weeks, and I say, "Oh, I'm so sorry you weren't able to get any care before now. Tell me why you weren't able to get it." And they said, "I'm uninsured. I'm undocumented. I didn't know that I could get health care before now." And so that is something that I think would be really, really helpful, and also to make a birth center affordable to be able to offer that service to our patients in the Denver metro area. Thank you.
Thank you, Shanti. Well, that actually takes us to our next topic. In the next 15 minutes, we want to talk a little bit about policy. And so I'm going to start with our one of our foremost policy experts, Representative Herod. And you and Senator Buckner, along with the Elephant Circle Leadership Group, were really instrumental in passing Senate Bill 21194, which extended postpartum coverage to Health First Colorado members from 2 months to a full year. Why is this important to you? And can you share how this extended coverage or other policies that you're interested in could make a difference for patients and families?
Yeah, absolutely. I mean, I'll start by saying that I am currently a member of the Joint Budget Committee. And so putting our budget where our values are is, I think, extremely important, and making sure that we have the resources that we need to align with our values and our values of care is important. And so that's really the basis behind that bill, and making sure that that coverage is there. I also think it's this is one of the places we can do more to prevent mortality. The data shows us that a greater portion of maternal mortality happens after that first 2-month mark. And if people can continue and maintain a continuum of care, they can prevent unnecessary deaths. So that's really just the baseline, though. We need to do more to prevent bad outcomes. We need to make sure that people are not just surviving, but thriving. And that means that we need more postpartum coverage, and not just like pushing people back to normal 2 months after childbirth. I mean, that is just not acceptable, and it's not healthy, and it's leading to these bad outcomes. And quite frankly, it's just not the reality for most people. So I think that this policy really coincides better with the truth that people are postpartum for more than 2 months, and that they should be and should have continued care for their well-being. But I think there's so much more that we need to do. We need to make sure that there are more screenings in place, and that there's access for these screenings For people, I think that's a equity issue. We need to have screenings for postpartum mood disorders, which I know some other folks will be talking about. We need to, I think, do more than just identify problems, though. We really need to value health. And that valuing of health is completely holistic. It's not just about whether or not you have that physical health, or you can pass basically an initial screening, but that there really is holistic health, mental, physical, spiritual. That's really where I think we're going to see better outcomes. And I need to add community health as well. That's how we're really going to change these outcomes. So we've got a lot of work to do. And I think that there are real policies that we can put in place to change this and untie bad policies to change outcomes. And I know that the folks on this call have solutions that they're sending to the legislature and compiling now. But I also know that there's folks not on this panel who have some great ideas too. And I just want you to know that my door, and I know Senator Buckner's door, is open for conversation, because this is a real priority for us. Quite frankly, I think if I told my mom or my sister or any other parent in my circle that postpartum is really only 2 months or even 1 year, they just laugh at me and say, clearly you don't know what you're talking about. You haven't had a kid yet, which is true, but also like not common sense, right? And so we just need to make sure that our policies align with the reality in our communities. And quite frankly, right now, they just don't.
Thank you so much, Representative. And I just really appreciate your open door policy is real. I hope that everyone on this meeting today can understand we are so fortunate to have such open access to our legislature and legislators that are so responsive to community. So I encourage you all to take her up on that. And I believe, Representative Herod, you do have to leave a few minutes early. So if you need to drop off, that is okay with us. We can move on.
Do. Yeah, I do. Let me just add one thing before I go, though, and that's one of the other initiatives that I'm working on with Senator Buckner, and that's to ensure that all pregnant persons in Health First Medicaid program have unrestricted access to those prenatal screenings that I talked about, and non-invasive prenatal testing. It's interesting because this equity of care issue, it's really a top priority for the American College of obstetricians and gynecologists. And so I think this is like really the next step that is almost a low-hanging fruit for us, but we really need to think beyond just care that's provided by the state of Colorado or our partners, and really think about the systems that serve all of us, right? And making sure that we're leading the way, and also incentivizing, encouraging, and requiring some of these changes to happen at the hospital level and at other levels of care as well. So anyways, just thank you so much for having me. Thank you for this conversation. I look forward to having more conversation with you all on these issues. And let's really make sure that we are moving the needle and not just having conversations that make us feel good, but actually make sure that our communities thrive and, quite frankly, survive. So thanks so much for having me. Bye.
Thank you so much, Representative. All right, let's move back to Christina for a little bit. So Christina, what are some of the policy solutions that can help reduce health disparities and support these multidisciplinary care teams that really promote access to doulas and midwives?
Yeah, so I know we're going to hear a lot about midwives, perhaps ad nauseum, but want to put in another plug. One of my favorite quotes that I've heard recently is, "Every pregnant person needs a midwife. Some also need a doctor." The literature is really clear that the shift to a midwife-led continuity of care model, even for folks who are deemed high risk, is an effective model in promoting equity and positive health outcomes. So when we're thinking about, kind of policy solutions that are related to this, we're thinking ensure that all credentialed midwives can get certified midwives reimbursed by Medicaid, right? We're thinking investing in prevention-focused care and incorporating prioritization of doulas and peer specialists and lactation support into systems planning and payment models. So a great example of a bill that was passed this past legislative session was Senate Bill 194, which their provisions aimed at all payers in Colorado, so both Medicaid and private insurance. but would increase access to midwifery care because it satisfies the 3 prongs of the criteria. So is the care high quality and cost effective? Is it evidence-based? And does it prevent risk in subsequent pregnancies? So yeah, Senate Bill 194 was incredibly fundamental in making sure we have greater access to midwives. And it parallels some work that's happening nationally as well. So nationally, there's efforts to kind of develop payment models that capitalize on data as to what's considered high quality and cost effective, evidence-based and preventative. And then the Institute of Medicaid Innovation is investing in midwifery-led models of care, recently completing an entire learning series in that regard, and then also sponsoring a state-based collaborative working to better integrate midwifery into care. So as Representative Herod mentioned, there's a lot of really great policy that's on the horizon. And I think we can really build off the momentum that we brought from this past session and really make some waves.
Thank you so much, Christina. All right, Dr. Latz. So as a regional accountable entity, you are responsible for administering a lot of the Medicaid benefits. So can you talk a little bit about the critical role that managed care plans play in maternal health equity, and maybe a little bit about how we might better support the 4th trimester and the mom baby dyad after in that postpartum space?
Absolutely. And let me start with that, Kristen, in a follow-up to Christina's comment, because I am also a huge fan of 194, which is so critical in that mom baby triad and extending care into the 4th trimester, that first year after birth. We're so used to thinking about the baby and what can we do to improve neonatal outcomes, but having the mom be covered and get adequate care and adequate screening for depression and treatment for substance abuse and treatment for all their other medical disorders is critical to that mom baby triad in improving birth outcomes and baby outcomes as well. So huge fan of 194 and super excited about that, both from a clinical perspective as well as from a RAY perspective and a coverage perspective. I think the advantage of the RAYs and of managed care is the ability to bring more local perspective and local care to maternity care. So for example, talking about birth centers, great, love it, I'm a fan, but we don't have very many in our region. I'm on the Western Slope primarily, our region, very rural. We've got one little urban area and the rest is all very rural. And some of our women, have to travel hours just to find any prenatal providers. So I would love to find additional providers of any sort that they can access. So access is a real problem. And so the advantage is we can bring innovation and we can bring, programs and initiatives that are specifically targeted to our population. For example, one of the things is I'm also a huge fan of group prenatal visits, very evidence-based, very clearly lead to better outcomes. But we have very few providers in our area that do it. So we are piloting a program right now where we're doing virtual group prenatal visits, where a woman doesn't have to leave her house, which is actually great during COVID as well, but can do a group prenatal visit on the phone, actually with women all over the country based on her gestational age. So really being able to target the programs and look for what's effective based on what's needed in our geography, what's needed for our patient population. In our area, we've got 2 Indian reservations and really being aware of the needs there, a very large Hispanic population. So being able to tailor the programs, meet the needs as much as we can, and look for innovation that will lead to better birth outcomes across the board.
Thank you, Lisa. I think we have 3 minutes left. And so I'm going to ask everybody for like a 1 to 5 word answer on this last question and then pass it over to Tracy to close us out. So what is it, if there's one thing you'd like to see in our next report, what would it be? And I'll start with Deidre.
Watching the data and seeing how the needle is moving. I'm so excited that we now have it. So let's keep your eyes on that.
Look at the trends. Okay.
Look at the trends as they improve.
Okay. Christina?
I'd love to see more data on the continuity of care for the perinatal period.
Okay, great. Lisa?
I would like to see a little more deep dive and root cause analysis into preterm birth rates and C-section rates.
C-sections and preterm, okay. And Shanti?
I would like to see some information about primary languages that patients are speaking, and about LGBTQ plus, IA plus communities.
Okay, great. We'll take that in for our next year's presentation. Thank you all so much for coming today, and for providing your perspectives. Oh, sorry, there you go. And with that, I think we are ready to close out the day. Thank you again.
Thank you so much.
Thank you, Kristen. I'll bring us home here in the last 2 minutes. You know, I feel like I could have listened to that panel for another 2 hours. So I hope that all of you will continue to engage with us, and did want to join Kristen in thanking the panel, thanking all of you for attending the webinar, thanking all of our stakeholders, some of whom were called out today, but there are many more that we haven't necessarily called out by name, but your dedication and collaboration is critical, and will fuel our collective efforts at bringing about maternal health equity. And on the screen here, you see the report link on our publications page. And again, if you haven't already taken a dive, hopefully this conversation today has enticed you to do so. And again, we do want to continue the conversation. We want to hear from you. So there will be some post-event communication materials. You'll see some of the results of the polls today. And again, just thank you for your participation, and thank you for your partnership. It's a very exciting journey we're on together, and really have a great day.